Hello students, hope you are all doing well. Topic for today's discussion is menopause diagnosis and management. We have to follow the NIGHT guidelines for it that is published in 12th November 2015, last updated 5th December 2019. Before proceeding toward these guidelines, we have to understand certain terminologies that what is menopause, perimenopause, early menopause and premature menopause. In menopause, what is menopause? Permanent cessation of menses, retrospective diagnosis after 12 consecutive months of amenorrhea. Average age is 51 years. What is perimenopause? Stage from the beginning of these menopausal symptoms, irregular menses, vasomotor symptoms to the menopause 12 months after the last period. Usually, it starts from 45 years of age in some women. Early menopause. What is early menopause? Menopause occurring before age of 45 years but after the age of 40 years. That is, its incidence is almost 5%. And what is premature menopause? Premature menopause is menopause occurring before the age of 40 years and its incidence is 1%. So for that we have to start treatment HRT or combined oral contraceptive until the age of natural menopause. So now proceeding toward the guidelines. So diagnosis of perimenopause and menopause. Diagnosis the following without laboratory testing in otherwise healthy woman aged over 45 years with menopausal symptoms. Perimenopause based on vasomotor symptoms and irregular periods, as I have told you before. Menopause in women who have not had a period for at least 12 months and are not using any hormonal contraception, and menopause based on the symptoms in women without a uterus. So in this paragraph they said that we will not do a laboratory testing in this type of patient age over 45 year of age. So in which patient we will do investigation, that is FSH, especially in those having premature menopause, the menopause that occurring before the age of 40 years. In that cases we will do FSH testing. So we will discuss later on. Taking in account that it can be difficult to diagnose menopause in women who are taking hormonal treatment, for example, for the treatment of heavy periods. Because these patients are taking hormonal treatment, so we have to sometimes will not the patient not present with any menopausal symptoms or any vasomotor symptom because they are taking hormonal contraception. So they say that sometimes it is very difficult to diagnose those are taking hormonal treatment. Do not use the following laboratory and imaging testing to diagnose perimenopause and menopause in women age over 45 years of age. That is AMH level, inhibin A, inhibin B, estradiol, interfollicular count, and ovarian volume. Do not use serum FSH test to diagnose menopause in women using combined estrogen and progesterone contraception or high dose progesterone because they will give you a false result. Consider using FSH test to diagnose menopause only in women aged 40 to 45 years with menopausal symptoms including a change in their menstrual cycle, in women under 40 years in whom menopause is suspected. So you have to memorize that in whom patient you will going to do FSH testing in women aged 40 to 45 years with menopausal symptoms and in other women under 40 years of age in whom menopause is suspected. So this will this will be your SBA, that in whom patient you will do FSH testing. Information and advice. Give information to the menopausal woman and their family members or carriers, an explanation of the stage of their menopause, common symptom and diagnosis, lifestyle changes, and intervention that could help journal health and well-being, benefits and risk of treatment for menopausal symptom. Long-term health implication of menopause. So explain to the woman that as well as change in their menstrual cycle, they may experience a variety of symptoms associated with menopause. So with menopause, we have certain symptoms. So when the patient present with this type of symptom, then we have to start treatment. Okay. If they cannot tolerate it, then we have to proceed toward the hormonal replacement therapy. Otherwise, we will start from lifestyle modification. So, what are the symptoms regarding to when variety of symptoms with menopause? They are vasomotor symptoms, for example, hot flushes and sweats. Musculoskeletal symptoms, for example, joint and muscle pain, effect on mood. Urogenital symptoms, for example, vaginal dryness. Sexual difficulties, for example, low sexual desire. So the menopause is important in both for you people in both it came in OSCE as well as in MCQs. SBAs came from these guidelines. Okay, so for OSCE you have to prepare it very thoroughly because in their favorite topic for OSCE exam. Such type of scenarios like when a patient came with the menopausal symptoms and she want HRT. So you have to take the detailed history from the patient that what type of symptom she is having. So according to that, you will prescribe her medication. If, for example, the patient have vasomotor symptom, so you have to start vasomotor for treatment for vasomotor symptoms. If patient have depressive symptoms, so you will start according to that. If patient have bone symptoms, then you have to start according to that. Like we have to start hormonal replacement therapy. So for OSCE point of view, this guideline is very important. So you have to listen it carefully that what type of question we have to ask from the patient. So these are the symptoms. So when the patient comes and you have to take the detailed history regarding the symptoms. For example, if patient have vasomotor symptoms, so you have to ask that how many times she develop a hot flushes, sweats in a day, in a week, or in a month. Then musculoskeletal symptoms, how was and detail regarding the mood symptoms to exclude any along with that any hidden depressive illness. So you have to take the detailed history from this type of patient. And if you are starting if you are planning to start for hormonal replacement therapy, then you have to take a detailed history regarding the any past history of any chronic medical condition that is contraindicated to hormonal replacement therapy. So, give information to the menopausal women and their family members the types of treatment for menopausal symptoms. Different types of treatment are hormonal, for example, hormonal replacement therapy, non hormonal, for example, clonidine, and non pharmaceutical, for example, cognitive behavioral therapy. Give information about contraception to women who are in a perimenopausal and postmenopausal phase because in perimenopausal you must have to provide extra contraception because there is chance of sometimes there chance of pregnancy. Offer women who are likely to go through menopause as a result of medical or surgical management, including women with cancer at high risk of hormone sensitive cancer or have a gynecological surgery, support, information about the menopause and fertility before they have their treatment, refer to health professional with expertise menopause. So in those cases, though having a cancers, high risk of hormone sensitive cancer, have gynecological surgery, so you have to take an expert opinion, even involve the multidisciplinary team. Managing short-term menopausal symptoms. Adopt a woman treatment as needed based on her changing symptom. Okay, so first we will discuss the vasomotor symptoms. If the patient have vasomotor symptoms, offer women HRT for vasomotor symptom after discussing with them short term up to 5 years and longer term benefits and risks. Offer a choice of preparation as follows: estrogen and progesterone to a woman with a uterus and estrogen alone to a woman without a uterus. So you have to memorize in whom you have give combined HRT, those having a uterus, and estrogen alone without a uterus. So an SP, if they have given that the patient is with having intact uterus and having a vasomotor symptom and you are planning to start hormonal replacement therapy, then you have to choose combined hormonal replacement therapy. And in those having without a uterus, so you will start estrogen only, because there is no uterus. You will not need progesterone, because if you give progesterone along with that, then there are studies regarding both the combined estrogen and progesterone, that they will slightly if increase the risk of breast cancer. Estrogen alone is not very harmful, but estrogen and progesterone both will have an effect on breast. Do not routine offers SSRIs or SNRIs or clonidine as a first line treatment for vasomotor symptoms alone. So these are certain medication that they will also helpful in vasomotor symptoms. They are antidepressants, but they are not as a first line treatment. Okay. Explain to the woman that there is some evidence that isoflurane or black cosh may relieve vasomotor symptoms. However, explain that multiple preparations are available and their safety is uncertain. Different preparation may vary. Interaction with other medicine have been reported. So you have to memorize about if the patient present with vasomotor symptoms, you have to take the detailed history regarding the vasomotor symptoms, that what is the severity. If the patient cannot tolerate, initially we can give, first of all, if the patient can tolerate, it is not so severe, then we will give a stepwise approach. We will tell the patient that she should take her lifestyle modification, avoid hot areas, and wear loose clothes, and especially the other things that we have to tell about, that if there is no improvement in symptoms, then we have to start. If severe symptoms and patient cannot tolerate, then we have to start on hormonal replacement therapies. So if the mild symptoms, we can also give her SSRIs or SNRIs for vasomotor symptoms, and it will have a greater improvement in symptoms, and about almost 45% the hot flushes can be reduced with these SSRIs or SNRIs. So the next symptom is psychological symptoms. Consider hormone replacement therapy to elevate mood that arise as a result of menopause. And consider combined behavioral therapy to elevate low mood or anxiety that arise as a result of menopause. Because only low mood we will consider hormonal replacement therapy, but low mood and anxiety, so there must be a slightly depressive symptom, so we will combine with the HRT along with the combined behavioral therapies. Ensure that menopausal women and health professionals involved in their care understand that there is no clear evidence for SSRIs or SNRIs to elevate mood in menopausal who have not been diagnosed with depression. So if the patient is having low mood associated with menopause, so we will not have to start SSRIs or SNRIs. And along with that, low mood, the other like anxiety, fear of hallucinations or any other depressive mood, and loss of activity in daily activity. So these are depressive symptoms. When you are suspecting menopause, when you are suspecting that the patient have menopause and low mood along with other symptoms, and you are suspecting any depression, then you have to start SSRIs or SNRIs. Altered sexual function. Consider testosterone supplementation from menopausal women with low sexual desire if HRT alone is not effective. Okay, you have to start. The patient have altered sexual function, so you have to if still the patient complain of low sexual desire, so you have to start testosterone supplementation along with HRT. So this is one of the SBA from Mrcog book, that the patient present with low sexual desire and she's already taking hormone replacement therapy, but you have to add another that her sexual desire have been improved. So you have to consider testosterone supplementation. Urogenital atrophy. In urogenital atrophy, systemic HRT have no effect on this, so you have to offer vaginal estrogen to women with urogenital atrophy, including those on systemic HRT, and continue treatment for as long as to relieve symptom. So in these two cases, altered sexual function and urogenital atrophy, you have to start topically. In altered sexual function, you have to give testosterone, and for urogenital atrophy, you will give topical vaginal estrogen. So in these cases, in altered sexual function, you will give testosterone supplementation in oral form, and in urogenital atrophy, you will give her topical vaginal estrogen. Consider vaginal estrogen for women with urogenital atrophy in whom systemic HRT is contraindicated after seeking advice from a health professional with expertise in menopause. If the vaginal estrogen does not relieve symptoms of urogenital atrophy, consider increasing the dose after seeking advice from health professional with expertise in menopause. Explain to the woman that symptoms after comeback when treatment is stopped. Adverse effects from vaginal estrogens are rare. They should report unscheduled bleeding to their GP. Advise women with vaginal dryness that moisturizers and lubricants can be used alone or in addition to vaginal estrogens. Do not offer routine monitoring of the endometrial thickness during treatment for urogenital atrophy. So the next step is complementary therapies and unregulated preparation. Explain to the woman that efficacy and safety of unregulated compounded bioidentical hormones are unknown. Explain to the woman who wish to try complementary therapies that the quality, purity, and constituent of product may be unknown. Advise women with a history or at high risk of breast cancer, although there is some evidence that St. John's wort may be of beneficial in the relief of vasomotor symptoms. This is uncertainty about the appropriate doses, persistence of effect, variation in the nature and potency of preparation, potential serious interaction with other drugs, including tamoxifen, anticoagulant, and anticonvulsant. So there is some evidence that those having breast cancer, St. John's wort may be of benefit, but the studies have not proven yet. Review and referral. So this is very important. When you have to start hormonal replacement therapy, when you have to review such type of patient. So review each treatment for short menopausal symptom 3 monthly to assess efficacy and tolerability. So you have to follow up the patient after 3 months and assess that whether her symptoms have been improved or not. If the symptoms have been improved, then we will proceed toward the annually thereafter. And if the symptoms are not improved, then we have to follow the patient after 6 months again. So if the symptoms improved after that, then we have to follow annually. Okay. Refer to the woman healthcare professional with expertise in menopause if treatment do not improve their menopausal symptoms or they have ongoing troublesome side effects. Consider referring to the woman to a health professional with expertise in menopause if they have menopausal symptoms and contraindication to HRT. There is uncertainty about the most suitable option for their menopausal symptom. If sometimes one type of preparation will not be helpful in some patient, but in these cases you have to change the drug. That sometimes one preparation will not be effective in one patient, and if you have to change the other preparation, other form of drug, it will be helpful for these patients. Starting and stopping HRT, it is very important. So this one is your SPA, that when you have to review, and both the OSCE and for both SPF, to remember that when you are counseling the patient regarding the different type of option, you have to if you are prescribing HRT, then you have to tell the patient that you have to come after 3 months, and if the symptoms are improved, then we will proceed toward the annual follow-up. Starting and stopping HRT. Explaining to the woman with the uterus that unscheduled bleeding is common side effect of HRT within first 3 months of treatment, but should be reported at 3-month review appointment and promptly if it occur after 3 months. Okay. So I will also discuss HRT in detail, but you have to only memorize at this stage that you will also counsel the patient that if the patient develop any unscheduled vaginal bleedings, and then she don't have to worry because it's normal up to 3 months. If it is more than 3 months, still the patient have symptoms of unscheduled vaginal bleeding, then we have to investigate such type of patient. So this paragraph is also very important. You have to memorize for both SPA and OSCE. Of a woman who are stopping HRT, a choice of gradual reducing or immediately stopping treatment. So better option is that you have to gradually reduce the dose. If the patient, for example, if the patient get menopause at 51 and patient having symptoms, so maximum up to 3 years you can give hormonal replacement therapy. If the patient symptoms have been any time, it's not important. If the patient symptom have improved, then you have to gradually reduce the dose. But maximum up to 3 months you have to go hormonal replacement therapy in such type of patients, especially those having advanced than those in whom reach the menopause. So because and later on there will be have a certain later on there are more side effects, because as age advances the side effects will be more. So maximum you have to give up to 3 months. Explain to the woman that gradually reduced HRT may limit recurrence of symptom in the short term, and gradually reducing or immediately stopping HRT may no difference to their symptoms in the longer term. Okay, so that's why we will offer both stopping HRT gradually or immediately stopping treatment. Women with or without risk of breast cancer. So this whole paragraph is very, very important. Okay. So in those who are high risk of breast cancer, women at or high risk of breast cancer, for advice on the treatment of menopausal symptoms in women with breast cancer or at high risk of breast cancer, of a menopausal woman with or at high risk of breast cancer, information on all available treatment options are: information that SSRIs, paroxetine and fluoxetine should not be offered to women with breast cancer who are taking tamoxifen. So you have to note these points, that in those patients who are having breast cancer, so you will not advise HRT. Memorize this, because this is very important regarding the OSCE and SPA point of view, and especially breast cancer. They came in exam as a OSCE station, that the patient present with the menopausal symptoms and also having a breast cancer, what type of treatment you will prescribe. Patient want HRT. So in these type of patient, those having breast cancer, current or previous breast cancer, you will not have to prescribe HRT. No HRT. Okay. Do you have to memorize it, that we will not give these HRT to these patients. So what other option we are available? So other option available, for example, if the patient is having breast cancer, the first thing we will advise have vasomotor symptoms, other symptoms. So vasomotor symptoms can be simply improved with SSRIs or SNRIs. Okay, because as patient is having only vasomotor symptoms, so this will be effective in regarding to vasomotor symptom. So in these type of patient, those having a breast cancer, we will prescribe these patient SSRIs, paroxetine and fluoxetine. And if the patient is having breast cancer, along with that she is on tamoxifen, then you will not have to give paroxetine, fluoxetine, you will give SNRIs, that is vilaxifene. So you have to, I will give you a slide for this menopause. So these are the buzzwords, and I have to make another slide for that you have to memorize this, that it is an important SBA. यूजुअली ये आपके एग्ज़ाम में आता है, ठीक है. और ये आपसे पूछते हैं कि अगर फॉर एग्ज़ाम्पल जो पेशेंट जिसको ब्रेस्ट कैंसर है, तो आपने कौन सा ट्रीटमेंट देनी है. तो HRT आपने नहीं देनी, आपने देनी है SSRIs. और जो पेशेंट ब्रेस्ट कैंसर है और अलॉन्ग विद टेमोक्सिफिन है तो उनको आपने SSRI नहीं देना, आपने उनको SNRIs देना है जो आपके पास वेलेक्सिफिन है, ठीक है। तो ये डिफरेंस आपने याद रखना है, ठीक है। और ये आपने अगर काउंसलिंग है तो काउंसलिंग में भी आपने ये बताना है, ठीक है, कि हम आपको HRT नहीं दे सकते क्योंकि इसके अपने साइड इफ़ेक्ट्स है, बिकॉज HRT विल ऑल्सो इंक्रीज द रिस्क ऑफ breast cancer. So if you have already breast cancer and if we are starting you on hormonal replacement therapy, then will further increase the risk of breast cancer. But if the patient symptom have not improved with the SSRIs or SNRIs, then you have to discuss with the oncologist. You have not to take decision alone that you have to start her on HRT, but in collaboration with the oncologist, you have to discuss that whether we have to start HRT or not. But you have to remember this, that SSRIs, paroxetine, fluoxetine should not be offered to women with breast cancer who are taking tamoxifen. So long-term benefits and risks of hormone replacement therapy. So you have also, when there is OSCE station, so you have to also tell the patient about the what are the long-term benefits and risk of HRT. The benefits are that her symptoms will be improved. Vasomotor symptom improve. Long-term benefit, usually it is protective for cardiovascular system, and it will have a greater impact prevention of osteoporosis and risk of cardiovascular disease. So the benefits for hormone replacement therapies are that. And what are the risks? The risks are venous thromboembolism. Explain to the woman that risk of venous thromboembolism is increased by oral HRT compared with baseline population risk. The risk of VT associated with HRT is greater for oral than transdermal preparation. The risk associated with transdermal HRT given at a standard therapeutic dose is no greater than baseline population risk. Consider transdermal rather than oral HRT for menopausal who are at increased risk of VTE and includes those BMI over 30 kg per meter square. So it came as an SBA that if the patient having BMI of more than 30, what you have to prescribe as an hormonal replacement therapy, then so you have to describe transdermal, not oral HRT. Because oral HRT have increased the risk of venous thromboembolism, so transdermal has less chances if the patient needed. Consider referring menopausal women at high risk of VT, for example, those with a strong family history of VT, hereditary thrombophilias, to a hematologist for assessing before considering HRT. Cardiovascular disease ensure that menopausal women and healthcare professionals involved in their care understand that HRT does not increase the cardiovascular risk when started in women age under 60 year of age. So up to 60 under 60 of age, so it will protective on cardiovascular system. But after 60, you will not prescribe HRT because it will increase the cardiovascular risks. Does not affect the risk of dying from cardiovascular disease. Be aware that presence of cardiovascular risk factor is not a contraindication to HRT as long as they are optimally managed. Okay, so there is no if the patient have cardiovascular risk factor, so it is not a contraindication to HRT because HRT is protective against cardiovascular system under 60 year of age. Explain to the woman that baseline risk of coronary heart disease and stroke for women around menopausal age varies from one woman to another according to the presence of cardiovascular risk factors. HRT with estrogen alone is associated with no or reduced risk of coronary heart disease, and HRT with estrogen and progesterone associated with little or no increase in the coronary heart disease. Okay, so both preparation with have no or reduce the risk of coronary heart disease. Explain to the woman that taking oral but not transdermal estrogen is associated with a small increased risk of stroke. Also explain that baseline population risk for stroke in a woman under age is very low. So one of the one of the long-term complication risks regarding to the HRT is that increased risk of stroke, but in usually not in under 60 year of age, it is very low, but above 60 year of age. So the difference in scroniarty per 1000 menopausal over 7-5 years. So they have to discuss that different preparation and what are effects on the patient. Those having age of less than 60 and more than 60, what are effects? Okay. So, and what is type 2 diabetes mellitus? Explain to the woman that taking HRT is not associated with increased risk of developing type 2 diabetes. Ensure that women with type 2 diabetes and all healthcare professionals involved in their care are aware that HRT is generally not associated with adverse effect on blood glucose control. So consider HRT for women for menopausal symptoms in women with type 2 diabetes after taking comorbidities in account and seeking specialist advice if needed. If only simple diabetes and there will be no nephropathy, retinopathies, means no any complications of diabetes, then you have to prescribe. It will have no side effects of HRT in case in diabetic patients. Breast cancer using the MHRA risk table explained to the woman around the age of natural menopause that the baseline risk of breast cancer for women around menopausal age varies for woman to another woman according to the presence of underlying risk factors. So the HRT with estrogen alone is associated with little or no change in the risk of breast cancer. I've already told you previously that alone will have little or no change in risk of, but the preparation of both estrogen and progesterone can be associated with increase in risk of breast cancer. So if you are prescribing HRT, so you have to if you are for example advise her both combined preparation, then you have also tell the patient that there will be increased risk of breast cancer in the combined preparation as compared to estrogen alone. So you have to outweigh risk the benefits. An increase in the risk of breast cancer is related to treatment duration and reducing after stopping HRT. So what osteoporosis? Advise the woman on bone health discuss their issues. Using table 3, explain to the woman that baseline population risk of fragility fracture for women around menopausal age in the UK is low and varies from one woman to another. Using table 3, that explain their risk of fragility fracture is decreased while taking HRT as that this is benefit. So it will have as I already told that the benefit of HRT is that will reduce the risk of osteoporosis. Is maintained during treatment but decrease once treatment stops, may continue for longer in women who are take HRT for longer. So they have a different current user, what are the population risks, have certain data. Dementia. Explain to the menopausal woman that likelihood of HRT affecting their risk of dementia is unknown. Loss of muscle and strength. Explain the woman that there is limiting evidence suggesting that HRT may improve muscle mass and strength. Muscle mass and strength is maintained through and important for activities of daily living. Okay. Diagnosis and management of premature ovarian insufficiency. As we have already told I've already told you previously that what is premature ovarian insufficiency. Premature ovarian insufficiency is menopause before the age of 40 years. So diagnose the premature ovarian insufficiency in women under 40 years of age based on menopausal symptoms, including no or infrequent periods, taking in account whether the woman has a uterus, and elevated FSH level on 2 blood samples taken 4 to 6 weeks apart. So it is very important that you have to memorize that in women under 40 years of age, you will do in menopausal case and age at least above 45, you will not to do any investigation, okay? But in those that are those having premature menopause, then we have to do certain investigation, and that is FSH level for confirmation. Okay, so for confirmation FSH level, and we have to take 2 sample. If for example one sample you have taken and it shows that FSH of normal FSH is up to 10 and it is more than 20, then you have to repeat 4 to 6 weeks apart for confirmation. So you have to memorize this. This is an SVA, that when you have to repeat the whether you have to take single sample or two sample. So you have to click that one, that we have to take two sample 4 to 6 weeks apart. So, for example, this is very important station regarding the OSCE station, premature ovarian insufficiency. So they have give you only, for example, patient present with menopausal symptom, age is less than 40 years of age, and FSH of more than, they have given you at least more than 30. Then you have to take the detailed history. There are certain causes we have discussed in later on in other lecture, that what are the causes of premature ovarian insufficiency. So in that case, when you take the detailed history and also rule out contraindication, if because you are prescribing HRT, so you have to also ask about the history regarding that contraindicate HR. If you are prescribing HRT, then you have to ask certain disease that are contraindicated regarding the hormonal replacement therapy. So you have to ask about that when because it is a single test, then when you are proceeding toward the management, then you also tell the examiner that I have to repeat this test, because we need two blood sample tests 4 to 6 weeks apart for confirmation of premature ovarian insufficiency, because it is a big diagnosis. You don't have to rely only on single sample. There may be a lab error. Okay. Do not diagnose premature ovarian insufficiency on the basis of single blood test. Do not routinely use AMH used to diagnose premature ovarian insufficiency. If there is doubt about the diagnosis of premature insufficiency, refer the woman to a specialist with expertise in menopause or reproductive medicine. Managing premature ovarian insufficiency offers sex steroid replacement with a child's choice of HRT or a combined hormonal contraceptive to women with premature ovarian insufficiency unless contraindicated. For example, in women with hormone sensitive cancer. So you have to choice of both. You can give both hormonal replacement therapy or combined oral contraceptive. So we will discuss later on these type of things. Okay, so explain to the woman with premature ovarian insufficiency the importance of starting hormonal replacement therapy either with HRT or COCPs and continue treatment until the age of natural menopause. So this is very important point, that in premature ovarian menopause, if it started at 35 years of age, so you have to continue HRT up till at least 50 years of age. The baseline population risk of disease such as breast cancer and cardiovascular disease increase with the age and is very low in women under 40 years of age. So you have to discuss that because there will be less chances of, because in HRT there will be a low dose of estrogen and progesterone as compared to combined oral contraceptive, because HRT is not used for contraception, but combined oral contraceptive we have to use for contraception. So that's why they have a high dose of estrogen. So before prescribing, if you are you have to plan that her age is 35, we can give her combined oral contraceptive pills. But and if you want that, if the patient want that, she doesn't want to get pregnant again, and so you have to start combined oral contraceptive. So before that, you have to rule out contraindication. That if there is any contraindication, then you have not to prescribe COCPs. Then you have to start hormonal replacement therapy, because it is having a, because in hormone replacement therapy there is low dose of estrogen. That HRT may be beneficial on blood pressure when compared with the combined oral contraceptive. Both HRT and combined oral contraceptive offer bone protection, and the HRT is not a contraceptive, as I have told you, because it is having a low dose of estrogen. But in COCP is high dose of estrogen, and so if you are prescribing HRT, then you will provide extra protection so that the patient can't be pregnant, because there in premature ovarian insufficiency there is 5% chance that the patient gets pregnant. And further, if patient get pregnant, then there will be have further certain complications in this pregnancy, because have certain complication in both fetus and mother. Give women with premature ovarian insufficiency and contraindication to hormonal treatment advice, including on both and cardiovascular health and supportive management. Consider referring women with premature ovarian insufficiency to healthcare professionals who have the relative experience to help them managing all aspects of physical and psychological health related to their condition. So this will be a guideline. It's a very beautiful guideline and they have explained very beautifully everything. So once you go through it and it's very easy topic. Maximum you have both the SPAs are covered. SPAs and those OSCE stations are mostly covered from this guideline. So you have to again read thoroughly, and those are preparing for OSCE. So read that guideline and make your own notes. So it will be very helpful. So thank you so much. If you have any queries, then you can ask in Talks group on WhatsApp group. Thank you so much.